Good evening. This is Dr. Sharon McQuillan, and welcome to the webinar on stem cells and anti-aging medicine, an update. And it is also an invitation for you to attend our pre-conference, which is going to be held on May 15th in Orlando in conjunction with the American Academy of Anti-Aging Medicine conference. And I'm very excited about the pre-conference because we have some of the best clinical researchers in adult stem cell therapies that are going to be presenting their work to you. So again, welcome. I am biased. I believe that this is the most exciting field in medicine today. And even though we're at the very infancy of this field, I believe that it is going to hold so much promise for improving what we can offer our patients going forward. Many of you know me. I'm board certified in family practice. I've been an anti-aging physician for 20 years, and I am in charge of the aesthetic fellowship and working toward creating a regenerative medical certification program. I'm the medical director of the Ageless Institute here in Aventura, Florida, and Ageless Regenerative Institute, which has been training physicians in the clinical use of adult stem cells for 6 years. I'm also the co-executive editor of New You magazine, and this magazine is really a magazine for anti-aging and regenerative therapies and contains a lot of content direct to consumer to help educate patients to be better consumers. And we're closely aligned with the American Academy of Anti-Aging Medicine in this effort. Regenerative medicine, as you know, is the process of using the human body's own repair and regenerative mechanisms to replace or regenerate disease or injured tissue. And I think for those of us who are in clinical practice, there cannot be a better model. So this is a new paradigm in medicine, and one that is, I know, embraced by all of you as anti-aging practitioners. It's a very new field, even though there are clinical trials ongoing throughout the world, but adult stem cell therapies are just one part of this. Research is ongoing for gene therapy, scaffolds, which will enhance our ability to localize cellular transplants, new delivery systems, and then growth factors and biologics to improve our therapies. So although the results that we're getting clinically today are excellent, I believe that the sky is the limit for what we can and will accomplish over the next decade. So if you're not currently doing stem cell treatments in your practice and you believe in health optimization, prevention, and more natural therapies, I think it is the next logical step. Patients are seeking alternatives to traditional pharmaceutical options. We as practitioners are looking for more regenerative therapies, more curative therapies, as opposed to just ongoing treatments. And this field holds the promise of a new tool. Stem cell therapies, it offers natural treatments to degenerative diseases without many of the side effects that occur with surgeries and pharmaceutical therapies. And the procedures can be done safely and effectively and in compliance with the regulatory bodies in your office in 90 minutes. And it's a local procedure so that it is a very low risk procedure that can be implemented into most practicing physicians' offices. We all have to understand how the time is valued in your office, because even though our primary motivation should always be patient care, patient outcomes, and superior therapies, the reality is that we still have to pay our bills, and it is becoming more challenging with the reimbursement structures and the current medical model. But just to give you an example of what can be generated from a treatment is a cell-assisted fat transfer generates between $5,000 to $10,000. This is for people who are currently doing aesthetic therapies in their office, maybe expert in fillers or liposuction, and they want a new therapy with predictable outcomes. The regenerative orthopedics, $5,000 to $10,000 per injection, depending on the area that you're in, what you're trying to accomplish. And then stem cells for treatment of degenerative disease under IRB research protocols are generally $7,500 and above in the clinic today. And there is a wide variation because, again, this is a new field and it's not as standardized as many therapies. What is able to be done in the United States today are adult stem cell therapies, which are autologous, and we can also provide banking of stem cells for future use, for culture expansion, and to protect the patient if they develop a disease in the future. But allogeneic cells are not currently properly used within the United States today. So let's focus on adult stem cell therapies that are autologous and what we can safely and legally do in the United States today. Adult stem cells are found in many tissues. They are undifferentiated cells and differentiated cells in tissue samples. The primary role of stem cells is to maintain and regenerate the tissue in which they are found. That is their function within the body, and they are busy at work constantly repairing tissue damage, protecting the body against degeneration. They're multipotent. They can differentiate into a subset of cell types, and they exhibit plasticity, which means they respond to cues in the niche environment, and that causes either proliferation, differentiation, or apoptosis. Mesenchymal stem cells are a cell of active interest because they have tremendous potential for many of the degenerative diseases that we're asked to treat today. They can be harvested from fat, bone marrow, or cord blood, and they are defined by, in cell culture, plastic adherence and fibroblast-like morphology. We tag these cells as with phenotypic characteristics as that they're negative for the cell surface markers, the cluster of differentiated 14, 45, 80, 86, and 83, and they are positive for the cluster of differentiation 73, 105, 166, 90. They have immunosuppressive properties, or immunomodulatory properties, and they can differentiate into down a adipogenic lineage, an osteogenic lineage, a chondrogenic lineage, and under the right circumstances into also muscle and neuronal tissue. This slide is from Arnold Caplan, who will be at our pre-conference, and he is considered one of the pioneers in this field. He actually coined the term mesenchymal stem cell, and we rely on his research. This is an electron micrograph showing that mesenchymal stem cells are actually periocytes. Periocytes are precursors to mesenchymal stem cells. And these cells exist around blood vessels throughout the body, and that is how they respond to cues to travel to areas of inflammation or injury or disease. We see a bimodal response in using mesenchymal stem cells. The initial effect is immunomodulatory, and this is with T cells, B cells, dendritic cells, and T regular cells. And then subsequent to that, we see a regenerative response. So the immunomodulatory response creates a healthy cellular milieu that creates a regenerative environment and calls other stem cells to the area and creates wound healing, wound remodeling, and tissue regeneration. So in the trophic phase, we see antifibrotic, angiogenic response, mitotic response, and cell proliferation and regenerative response. So the cells work in a couple different ways, and that is, a bimodal response. Initially, we see downregulation of inflammation in immunomodulatory phase, which is why, for example, we see an almost immediate effect when we inject a inflamed joint. Quickly, we see reduction in inflammation, reduction in pain, but as we know, it takes time to regenerate cartilage, to repair the synovium, and to improve the health of the joint. So it's important to have viable cells to get both responses. There's an ongoing question about whether or not it's better to harvest mesenchymal stem cells from bone marrow or from fat. And experiments show that basically they're the same cells. They originate in bone marrow and then they migrate to the adipose tissue. So this was accomplished by radiotagging the mesenchymal stem cells in bone marrow and treating laboratory animals with high-fat feeding. The cells then trafficked to the adipose tissue and fluoresced there. So I think that most of us have evolved to thinking that adipose is preferable as a harvesting site because the cells exist in much higher number. So if you have in bone marrow, you can have, in adipose tissue, you can have up to 500 times the number of stem cells per cc of adipose tissue. So it's just an easier harvest. We don't have to culture expand to get adequate numbers to exert a clinical effect. And so that is sort of the best way today in the United States to offer these therapies. In bone marrow, and there's nothing wrong with the bone marrow source, it's great. It's just that in order to get adequate numbers of cells, it's necessary to do culture expansion, and that is specifically prohibited under the Federal Code of Regulations. So I think that as the field standardizes, we'll understand the best way to use the two different sources, but we're limited in the United States at this time in using adipose tissue if you want higher numbers of stem cells for a particular clinical therapy. The cytokines that are released by stem cells include hepatocyte growth factor, which, as we know, plays a major role in embryonic organ development, vascular endothelial growth factor, which stimulates the growth of new blood vessels, placental growth factor, encourages angiogenesis and vasculogenesis, and transforming growth factor beta, which controls proliferation, cellular differentiation, and other functions. There's a moderate expression of fibroblast growth factor and angiopoietin. So once again, thinking back to the immunomodulatory effect and the trophic effect, the way that these effects are clinically manifested is through the release of growth factors and cytokines, and not simply utilizing the stem cells as building blocks. The stromal vascular fraction is the term given to the cell isolate from adipose tissue, and it's shown here to be a mixed cell population, which exerts a beneficial effect. It consists of hemopoietic cells, pre-endothelial cells or endothelial progenitor cells, periocytes and smooth muscle cells, fibroblasts, others, and also adipocytes or pre-adipocytes. So it's a mixed cell population, and it seems as if the mixed population works better together than a single cell type. And if you think about the mechanisms in the body for tissue healing and tissue remodeling, it is a mixed cell population that is employed. Current accepted methods for adipose-derived stem cell isolation include tumescent liposuction, removing of the red blood cells because they impede proliferation, enzymatic digestion to release the stem cells from the adipose tissue, centrifugation to separate the stromal vascular fraction, and then isolating the stromal vascular fraction, filtering it, and then preparing the cells in final suspension. Collecting stem cells is all of the different steps mentioned previously have to be standardized in order to control the variables to yield a standardized cell product. And I think if we are going to treat patients with a cell product, it's incumbent on us to have a defined cell product that we can reliably understand what we're injecting into our patients. So it can be affected by surgical technique, and that includes the tumescent anesthesia you use, the type, the amount, the cannula size, the suction pressure, the location of tissue harvested, the method by which you use enzymatic digestion, because these enzymes are biologics and they exert very different activity levels depending on the batch and the specific blend of enzymes. The separation technique, the incubation times, the quality of your reagents, all have to be very, very controlled in order to get a predictable cell product. And the cell product needs to be validated for sterility, cell yields, cell characterization, and lack of toxicity. And this will need to be demonstrated if you are ever, reviewed or asked about the techniques that you're using. And I think it's very important, not only for your conscience as a physician to know what you're injecting into patients, but from a regulatory standpoint. If you're considering offering stem cell treatments, or you currently are offering stem cell treatments, it's imperative to have a validated and standardized method yielding a defined cell product. It has become important to use good manufacturing practices for the consumable manufacturing. And a word about that, ask suppliers for their certificate of GMP. Many people out there are representing that they are certified under good manufacturing practices, and they are not. It's a big deal, and I've come to respect it quite a lot in terms of the requirement. Approved equipment. Make sure that your equipment is approved within the United States. that you have approved and defined solutions, and that you have good laboratory practices with appropriate record keeping, and that you're operating under clinical IRB approved protocols for a number of reasons. One, so that we can help to understand the success of the different therapies so that we can better define patient selection, patient outcomes, dose ranging. Two, that you have very good record keeping and you use a standardized technique so that if you are ever questioned about the therapy that you're using, you have very clear guidelines and rationale for doing what you're doing. We can then collectively produce data which will be valuable to all of us going forward. And then from a regulatory standpoint, it's necessary. The clinical application of stem cells, and I'll share a little bit about results, and then I want to introduce our speakers for the pre-conference. In regenerative orthopedics, the technique utilizes platelet-rich plasma in patients with degenerative diseases and musculoskeletal injuries in conjunction with cells. So it's the stromal vascular fraction suspended in 5 mils of PRP and injected into osteoarthritic joints using a defined cell product and a sterile technique. And we have a great deal of experience in our clinic utilizing this therapy, using visual analog pain scales and present pain inventories. We have a 73% improvement over baseline with just one injection. And if you think about that, there's going to be 40 million Americans with osteoarthritis, and we don't really have good solutions other than regenerative therapies. We have nonsteroidals, which create problems, Kenalog injections, which is ultimately catabolic. We have the biologics, and those affect or impact the immune system. And then we have the hyaluronans, which are injected into the joint, and those are not regenerative, but do provide symptomatic relief temporarily. So in my view, we have a significant problem with no really good solutions outside of regenerative therapies. This was a paper that was published recently, and it was 18 patients that were injected with adipose-derived stem cells for osteoarthritis at 3 different doses, attempting a dose-ranging study. And the primary outcomes were functional capacities. Secondary outcomes were histology, arthroscopic, and radiologic. The WOMAC score showed improvement in all groups, most significant in the high dose group. The knee pain decrease in tendency over 6 months and was significant in the high dose group. Size of the cartilage defect increased in the high dose group. Obviously, we need a larger N, and histology demonstrated thickened cartilage regeneration. So I'm always asked if we have histology or if we have MRIs, and unfortunately we've not yet had the funding to do that, although we are attempting to acquire funding, but this has been published recently. So we do have evidence that the stromal vascular fraction, when injected intra-articularly, does improve cartilage regeneration, and they have similar results in terms of pain reduction and improvement in function. So this was the stromal vascular fraction for osteoarthritis in the knee at 6 months, showing improvement at all doses, but the most improvement was at the mid-range dose. These are the arthroscopic photographs showing improved cartilage. This was a poster that was presented out of the Mayo Clinic. A landmark study from the Mayo Clinic was presented at the American Academy of Pain Medicine, and there was a meta-analysis of the animal studies shown with stem cell treatments, and it showed increased intervertebral disc height by more than 23.6% and increase disc water content and improve gene expression. Again, I will say we don't really have any good solutions for degenerative disc disease. The nerve ablation therapies and the fusions are not really helpful long term, and we have a significant number of people with back pain in the United States with no good solutions. So I'm looking forward to this. We're actually working with a hospital currently that sees a very high volume, and we're about to embark on a similar study for intervertebral disc injections. Congestive heart failure. 5 million Americans suffer from heart failure, 1 in 9 deaths included as a contributing cause. Half of those who develop heart failure die within 5 years. Again, a condition that we don't really have good solutions for. It costs our budget $32 billion per year, and the best we have to offer is pharmaceutical intervention or biventricular pacing or heart transplant. And the congestive heart failure study that we did in conjunction with BioHeart at the Regenerative Medical Institute in Tijuana had as the primary outcome measurement safety, secondary outcome measures, changes in left ventricular ejection fraction, and exercise capacity and quality of life. These cells were the stromal vascular fraction delivered by needle injection cannula into the left ventricular myocardium. Exercise capacity increased 128 meters and at 3 months, and the left ventricular ejection fraction increased 11%. So these results are very encouraging, and this trial is still ongoing. COPD. It was the third leading cause of death in America. 12.7 million U.S. adults estimated to suffer from COPD. Close to 24 million adults experience impaired lung function. 47 million Americans have emphysema. Again, a condition that we have medical management. It's a chronic progressive disease. Patients get it, and they continue to progress, toward dysfunction or death, unfortunately. So with COPD, a simple IV injection of the stromal vascular fraction will deliver 90% of the cells on a first pass effect to the pulmonary tissue, and the primary outcome measurement was safety, secondary outcome measures, pulmonary function, exercise capability, and quality of life. The St. George Respiratory Questionnaire is the standard quality of life questionnaire for pulmonary patients. And if you have a decrease, it's good because it speaks to symptomatology. So at 3 months, we had improvement, and at 6 months, that improvement was maintained. The 6-minute walk distance improved at 3 months. Some of these patients are able to reduce their medications, reduce their oxygen, or come off of their oxygen. It's especially impressive if there is a bronchospastic component, and many patients that I personally have treated with asthma are no longer needing to use their rescue medications, have not had hospitalizations, are far more stable in their disease, and have improved pulmonary function testing. But 34 patients were treated in the trial to date, average increase of 22 points in the St. George Respiratory Questionnaire, average increase of 70 meters in a 6-minute walk test. And again, if you think about it, we have no good solutions for these disorders. Peripheral artery disease affects 8 to 12 million. It's an elderly population. Patients with heart disease have a 1 in 3 chance of developing peripheral artery disease. Those who smoke have a 4 times greater risk of developing peripheral artery disease, as we know. These are slides courtesy of Dr. Prokaska from the Czech Republic, who did a pilot study with stromal vascular fraction. And these are patients who failed revascularization attempts, and at 60 days, he was able to salvage 75% of the patients and prevent amputation. And again, unheard of. I think this slide really says it all. In my view, there's nothing that we can do that would be more important than this. To be able to create an angiogenesis to improve circulation has, far-reaching implications for our field and for many of the things that we are asked to treat. This is a patient that had radiation necrosis from treatment of a squamous cell cancer. She had had multiple attempts at skin grafting, wound healing, and it was recommended to her to have an amputation. At 7 months after one treatment, she was able to heal, and she is fine today. Her CT angiogram showed complete normalization of the vasculature at the radiation site. This is a patient who was in a traumatic accident that we treated in Mexico, and again, a testimony to the wound healing capability of the stromal vascular fraction. So in treating these chronic degenerative disorders, of these and more, we have 30 different IRB protocols for neurodegenerative disorders, ocular disorders, hepatic disorders. Almost any subspecialty that you come from is probably conducting active research with adult stem cell therapies, or should be. And we've learned from our patients that multiple cell types may become necessary. Adipose-derived, bone marrow-derived umbilical cord cells, in the future, allogeneic cells, culture-expanded mesenchymal cells. And again, I don't pretend that we have all the answers today. We probably have more questions than answers. I do know that the stromal vascular fraction works, and it works well for many things, but I think we'll perfect this knowledge by collaboration and effective research going forward. You can add these abilities to do adult stem cell therapies in your office today. We always recommend that you consult a healthcare lawyer in your state, because your individual state governs your medical license, and there is variability from state to state about the medical board tolerance for cellular or regenerative therapies. It's not possible to advertise that cellular medicine cures or treats any specific condition, because we don't have double-blind placebo-controlled studies that would allow us to make those claims to the public. It is important to make sure that your fees are in line with similar procedures, so that you can avoid attracting negative attention, which is termed patient gouging. And then it's important to make sure that your consent promises no specific outcomes and clearly states that this is experimental medicine. When I first saw this, I was intimidated by it, because I wasn't really certain how I was going to tell my patients that I was practicing experimental medicine. But I was surprised and pleased to find out that patients know this. They actually embrace it, and patients have a very low threshold for believing that stem cell therapies can help them, and they're interested in being involved in research for natural therapies. So, I had to overcome that, but actually my patients helped me with that. Utilize a scientifically validated system. This is important. The FDA has visited offices which are advertising cellular therapies, and to date, the offices that are using good manufacturing practices, and they have a validated system, and they have good laboratory practices, and they are working under IRB, have been allowed to continue. In the absence of that, there are many offices that have been asked to stop. On May 15th at the Gaylord Palms in Orlando, Florida, we are offering a pre-conference with a group of excellent physicians that have done important research in the field of adult stem cell therapies. And our faculty is pictured here. Arnold Caplan, as I mentioned before, is a professor of biology and is the director of the Skeletal Research Center. He's at Case Western University, and he has published over 150 abstracts and is really considered one of the leading pioneers in this field. I've referenced many of his slides throughout the presentation. He termed the term mesenchymal stem cells and periocytes, and is really a thought leader that I feel privileged to have him on our agenda. Mark Holterman is an associate professor of surgery in the division at the University of Illinois. He's done extensive research on umbilical cells and the control of the autoimmune process in diabetic patients. And his presentation will be on the treatment of diabetes utilizing umbilical cord stem cells. Adeeb Al-Zoubi is a PhD and assistant professor at the University of Illinois College of Medicine. He is the CEO of Stem Cells of Arabia and has numerous journal publications regarding cellular therapy and gene therapy. His presentation will be on the advances in diabetic treatments with adult stem cells as opposed to umbilical cord. Augusto Brazzini is an interventional radiologist, and he's the founder of the Brazzini Institute in Lima, Peru. He's known for his work with bone marrow derived cells in Parkinson's disease and assisted us in writing our Parkinson's protocol. His presentation will be on the role of the regenerative medicine in Parkinson's disease, and he has the most experience in the world in treating this prevalent disorder. Wade McKenna is a board-certified orthopedic surgeon and the director of McKenna Orthopedics in Decatur, Texas. He's the chief medical officer and co-founder of Biologic Therapies and the developer of the Biomac bone marrow aspirator catheter. And he has one of the most active practices treating orthopedic patients with stem cells. And he'll be presenting regenerative orthopedic treatments and advances in musculoskeletal repair and regeneration. Neil Riordan, friend for a long time. He's chairman of Metastem Research Laboratory in Panama, and he is a pioneer in allogeneic stem cells and the first to discover that mesenchymal stem cells exist in menstrual blood. He has been very active in both research and in his clinic in Panama, and treats a large number of patients for a variety of different disorders. He has 20 research articles on stem cells for the treatment of MS, spinal cord injury, heart failure, rheumatoid arthritis, and autism. And he'll be presenting on the utilization of autologous stem cells in the treatment of autoimmune disease. Rafael Gonzalez is a PhD and a colleague and a wonderful researcher. He's vice president of research and development at Da Vinci Biosciences, also involved in a company called ReHealth. And Da Vinci Biosciences is very active in producing cell types and tissue for research to academic institutions and pharmaceutical companies worldwide. ReHealth is a clinic where many of these therapies are offered, which exists in Guadalajara, Mexico. He's responsible for the development of clinical stem cell applications for several disease states and trauma states, author of numerous research and clinical studies regarding stem cells, and he'll be presenting on the importance of standardizing and characterizing cell products and cryopreservation and culture expansion of stem cells. And I had the opportunity to visit the Da Vinci Biosciences laboratory not long ago in California, and it's state of the art with just brilliant researchers that are very involved in advancing this field. David Audley, he's the CEO and managing partner of Good Partners, and he has been instrumental in helping regulate, standardize, and elevate and promote this field since its inception. He's the chairman of the IRB of the International Cell Surgical Society and is the chairman of the board of Regenerative Technology Alliance. And he will be presenting the state of the cell, global applications of stromal vascular fraction worldwide, and the importance of conducting IRB clinical trials within the United States and abroad. David has been involved for the last 6 years that I know of in helping physicians start practices, start offshore clinics, standardize their therapies with good IRB protocols, and to provide quality assurance and so on. So, and he also has had quite a bit of communication with the FDA and has a good handle on the FDA's position. So our goal is to acquaint you, and we have other speakers as well, but I've taken enough of your time tonight. But our goal in presenting this pre-conference is to introduce you into people doing important but relevant clinical research in their practices and their clinics so that we can share our experience. And I want, through their education to understand how adult stem cell therapies inhibit inflammation, inhibit apoptosis, encourage angiogenesis, support wound healing and wound remodeling, and how they improve these different disease states that these speakers will be talking to you about, to discuss the benefits of adult stem cells, umbilical cord cells in the different disease states, probably allogeneic versus autologous, and it should be a very good exchange and a very rich environment for interaction. So, we will address, how stem cells participate in healing diseased tissue, how you can implement compliant stem cell therapies in your office, and what is proper and what you're able to do within the United States. The treatments for the following conditions will be discussed. There's COPD, autoimmune disorders, wound healing, vascular disease, diabetes, heart disease, orthopedic conditions, Parkinson's, and Alzheimer's. And we will also discuss PRP, the different systems that are out there, the different research that is available, and again, how you can bring these therapies to your clinic in a responsible and in an educated manner. So the Academy has told me that you can have a $100 discount for if you register after attending this webinar. And it's my hope that you will all come because it's my goal to help standardize and elevate this very important field. And so it's my hope that you're there for the education, but the Academy wants to encourage you to attend by offering you a $100 discount. And you can contact Janet Daher at jdaheragelessinstitute.com, and I will be happy to take any questions. Okay, I have a question as which stem cell biotech company seems to have a cutting-edge lead on the future realistic application of stem cell therapies for tissue repair or regeneration and or maintenance in the is the neural stem cell company a viable entity, for example? I'm aware of many researchers which are currently doing clinical work with different cell types, either mesenchymal stem cells, both autologous and allogeneic, and with the stromal vascular fraction for the neurodegenerative disorders. As far as a biotech company, I'm not really certain about neural stem, and I don't know what specific disorder you're addressing. So if you come to the conference, I'm sure collectively we'll be able to answer your specific question, but I don't want to comment specifically on the technology of neural stem. Yes, actually, I had a patient with the question is, has Charcot-Marie-Tooth disease been treated, or Charcot-foot? Oh, no, okay, I'm sorry. I misread the question. It's, has a Charcot-foot been treated with stem cell therapy? Not by our clinic, but I believe that it would depend on the actual state of the joint. Again, you'd have to really assess what you can accomplish with stem cells. What I typically tell my patients is we can regenerate tissue to a certain extent, but we're not going to restore structure that previously existed. So it would depend on your specific patient and their specific goals as to whether or not a surgical modality or a regenerative therapy would be appropriate. The question is, what is my experience with PRP treatment as a standalone therapy? Well, it's currently being used in aesthetics and also in orthopedics and in some of the chronic pain procedures. And PRP in aesthetics has not really lived up to my initial hopes. I think that PRP plus fat-enriched stem cells is a very good aesthetic treatment, and we've had brilliant results with that. PRP alone did not really impress me in terms of skin regeneration or rejuvenation. For orthopedics, we use PRP for mild strains and sprains, for acute mild tendinitis, but for anything significant, for example, for osteoarthritis or for a partial ligament tear or for a meniscal tear, then we go straight to stem cells plus PRP because the combination works far better. Can you expand a bit on the use of stem cells for Alzheimer's disease? There are many different attempts at treating Alzheimer's disease at this point in time, and unfortunately, I'm not aware of any properly conducted data collection process. And so anecdotally, many people are currently being treated with the stromal vascular fraction and with mesenchymal stem cells. There are different routes of delivery. They've been injected directly. They've been given IV. They've been also given with in conjunction with mannitol to improve crossing the blood-brain barrier. But I don't believe anybody to date has done an excellent job at data collection to really vet a specific outcome. What we do hear in the field from many clinical, practitioners are that patients have an improvement in short-term memory, an improvement in orientation, an improvement in just their clinical state. But I think that we need to do a far better job at screening patients, doing patient selection, and using outcome tools as measurements for these outcomes. So we do have experience in treating Alzheimer's patients. It has been positive. How long it will last and what exactly we can anticipate from that, I'm not certain yet, but we do have a recently approved clinical IRB study, and we hope to be able to report more data in the near future. If I had it, I would certainly have the treatment because it's proven very safe. But I don't think that you can promise your patients any specific outcome. So we definitely need more work in the neurodegenerative disorders. I think Dr. Brazzini may be able to speak to that because he's done a lot of work in that area. So again, a plug for the pre-con. Is there a director of doctors trained at the... My what? My oat. I'm sorry. It says, is there a directory of doctors trained by the A4M who offer adult stem cell therapy treatments? And no, that does not exist to date. It's something that we can work toward. It says, one thing is that I'm not certain I understand this question fully, but it says that there are adhesions resulting from radiation therapy for breast cancer. That would, of course, depend on how is the patient cured? Are you 5 years out? Are you sure that you're cancer-free? And in that particular instance, then you can consider treating adhesions with, the cell-assisted lipotransfer. And there have been patients that have been treated for specifically this with good success. So Harold, are there other stem cells other than adipose cells that are legal to use in the United States? Yes, there are. It is legal to use bone marrow-derived cells, or BMAC, but in harvesting bone marrow, you don't get adequate numbers. So there are just 500 times more cells available in adipose tissue, and most patients do have adequate adipose tissue so that you can, do a proper harvest. We also treat performance athletes, and the performance athletes that we treat sometimes, unfortunately, don't have enough fat. And then we may choose to utilize bone marrow plus PRP plus a fat graft. And, that is currently done for orthopedic and pain intervention. Other than that, autologous adult stem cells can be used in the United States. It's curious to me because, there is a cord blood banking industry, and it's allowed and proper to bank cord blood for our children. but still it's not possible to utilize those cells within the United States. So I think, as we grow as a field and as we have more of these things available to us, we'll be better able to offer our patients a more expanded menu. Is it legal to culture stem cells? Well, it is certainly legal to culture them. It's just not legal to culture them and then use them. I mean, stem cells are cultured in research laboratories every day. We have cultured stem cells in the past and ongoing, but it is not proper or legal to use culture expanded cells within the United States today. And actually, that decision was reaffirmed by a court decision just recently, that at the appellate court level, a unanimous decision was that culture expanded cells should be viewed as a investigational new drug. So it is not possible to culture expand them. There was a piece on 60 Minutes, and it was just such an unfortunate piece. It was by physicians that were unscrupulous, charging large amounts of money, making false promises to patients, and representing, for example, that they could cure them from ALS. And so it attracted regulatory scrutiny. As it turns out, the physician was not a licensed physician. It was a complete scam. And unfortunately, many patients were affected in a terrible way. It was just heartbreaking. So on that segment, they said that there are no FDA-approved indications, which is true because these are live tissue, live cells, and the FDA currently regulates drugs and devices. And we know we have a long history in our practices of doing skin grafting, bone grafting, tendon grafting, and that has always been the practice of medicine. So so it's not that they're not approved, it's just that it doesn't apply. An application for hair therapy. There are several ways to look at hair loss, and if you have someone who's completely lost their hair follicles, then in the future, I believe that we'll be able to implant new hair follicles, but we're not there today, except with hair transplant surgery, which, it is what it is. If you have someone who is losing their hair follicles, but they are still present and somewhat viable, but degenerating, so thinning and decreasing in number, you can increase the hair coarseness and the hair density by injecting a combination of PRP and the stromal vascular fraction directly into the scalp. And we have done that with good success. There are also, I believe, studies going on looking at this in combination with hair transplant surgery to improve the viability and the take of the grafting. The next question is, do we see an increase in pain after stem cell injection before it gets less for ortho conditions? This is very patient specific on what condition you're treating, and also patients seem to have an individualized response. I believe that the pain immediately after injection is either going to come from needle trauma in a tight joint, or if you introduce white blood cells in your PRP. The vast majority of our patients do not experience an increase in pain. Occasionally, I would say 10% of the time, we do have someone that has a sore joint for a couple of days, but as we've gotten better and we do things under ultrasound guidance, we are very specific not to include white cells in our PRP. we have really decreased our incidence of painful swollen joints post-injection. Okay, and this is the last question. For rotator cuff tears, is bone marrow-derived stem cells as good as adipose-derived? Again, there's a wide variation in rotator cuff arthropathy and exactly what you're trying to treat. So it's somewhat dependent on that. If it's just a specific and acute partial tendon tear in a healthy joint, then I think if you use bone marrow and PRP, you probably would have adequate cell numbers to repair that cuff. However, the majority of people that will come to you, other than performance athletes for stem cell therapy, are going to be older patients that also have degenerative arthritis, maybe multiple different structures within the rotator cuff that are affected. And so it's better to have more cells. So adipose cells are still going to provide you with the same cells in higher number. And, we can teach you to do that so that it's very easy to harvest the fat. And most people feel that the fat harvest is easier to go through than the bone marrow harvest. So yes, the bone marrow cells are great. Adipose-derived cells in the stromal vascular fraction are great. It's just a question of what are you trying to accomplish, and what kind of dosing do you want or need. So I thank you so much for your participation. They were great questions, and I hope that all of you will come to the pre-conference where we continue these discussions, introduce you to some great researchers in the field, and continue collaboration and helping to grow this important field.